Buenas tardes a todos en España. Good morning in Canadá. Vamos a empezar con el webinar de la Asociación Española de Cirujanos, uno de los webinars que se han presentado antes del congreso que tendremos en Alicante. A los que estéis todavía más rezagados, pendientes de apuntaros, os animamos a venir aquí a Alicante semana que viene. Y hemos preparado realmente un webinar, creo que es súper interesante, con ponentes que ahora presentaremos, que yo creo que es un lujo el poderlos tener. En primer lugar, agradecer a la empresa Fresh News la posibilidad de tenernos aquí y tener a tales eminencias con nosotros. Participará en el mismo, moderará el doctor José Manuel Ramírez, que es de sobra conocido en España y fuera de España. Es el mismo presidente de la Cátedra de Rehabilitación Multimodal y el padre, aunque no le gusta, sé que no me gusta decirlo, de la rehabilitación multimodal en España. Y copresentaré con él, que soy Antonio Arroyo, cirujano aquí del Hospital de Elche y uno de los organizadores de la semana que viene del Congreso, lo que os esperamos. Y tenemos, bueno, como os comentaba, unos ponentes yo creo que de lujo. El profesor Franco Carli, que no hace falta presentarlo, pero él es anestesista en Montreal y realmente es el padre de la prehabilitación. Todos los conocemos que nos dedicamos a esto. Y nos va a dar una charla que seguro que nos encanta y nos abre la mente para el futuro de la prehabilitación a nivel mundial, lo que nos espera. También tenemos el honor al profesor Carlos Feo. Él es profesor y director del Departamento de Cirugía de Ferrara y es uno de los líderes que ha participado en el proyecto UPNM, que es un proyecto europeo que nos contará él, en el que a nivel nacional, por suerte, hemos podido participar tanto el Hospital de Elche como Zaragoza, y nos va a contar el proyecto y la importancia que ha tenido a nivel europeo de la implantación de este programa. Y en último lugar nos dará una charla la doctora Julio Con, que es jefa de sección de nutrición del Hospital Lozano Blesa Zaragoza, que por motivos de agenda de coincidir con un congreso suyo ha grabado la presentación y nos dará una charla seguro que estupenda y fantástica de nutrición y bueno, me pide que se excuse porque le hubiera gustado estar aquí con nosotros. Y bueno, vamos a empezar, haremos las 3 charlas consecutivas. Ya sabéis que tenéis abierto el chat, cualquier panelista para ir preguntando y trasladarle luego a nosotros las preguntas tanto a Carlo como a Franco. Pues nada, vamos al grano y a disfrutar de esta horita que tenemos con el profesor Franco y el profesor Carlo. Empezará con el profesor Franco Carli para contarnos la prehabilitación. Muchas gracias a los dos. Thank you very much, Franco and Carlo.
Muchas gracias. Buenas tardes a todos. Voy a hablar en inglés. Es muy fácil conmigo. Rehabilitación. I chosen this title from risk assessment to intervention, just to facilitate the discussion tonight as well. I think the objective are, first of all, the proof of concept, why rehabilitation can be actually a concept and a proof. Then I'm going to talk why, what, when rehabilitation should be included, and also perspective of future of rehabilitation integration into ERAS program. I strongly believe that with the culture of ERAS, rehabilitation makes sense. I don't have any conflicts with the frame. So this is the classical wheel that everybody knows, established by the ERAS Society, as you can see. And I instantly put rehabilitation in the pre-admission part, obviously. So this is the area when we actually preparing the patients. Now, if we actually look at, for the moment, the concept of ERAS program, as you probably know, the idea of the rehabilitation was to move around and identify what are the elements which really are modulating the response to surgery. And you can see I have a minimal invasive surgery, classical, everybody realizes. I'm talking to surgeons, and we know very well that there's been a lot of work on that as well. But of course, alone is not really changing much per se, the outcome. And then, of course, all the modulation of stress response, when we talk about, from from opioid, from minimally invasive sedative, from avoiding a large amount of fluid, and also to making the patients more awake at the end of their surgery as well. And of course, preoperative morbidity, thinking about optimizing hypertension, optimizing diabetes, and so on. But hold on. But are we really doing anything from the point of functional status? And I'm just going for a moment on functional status, and I think I'll show you why is important. So when actually we're talking about stratification of and prediction of the stress, we're really doing because we want to really allocate medical resources. So we say, if the patient is high risk, well, we're thinking about going to the postoperative care unit, or we're going to the ICU. But the question is that, can we move around from just allocating, thinking about what the patient can be, to actually intervene? And why is intervening? Because intervening will be optimizing this functional status, which is therefore mitigating the risk, and also shared decision making. We're talking more and more patient-centric, very much. That's what we need to solve. We need to share the decision, not only with our surgeons, with anesthesiology, but internal medicine, but also with all the group and the patient, obviously. Now, I'm sure you all know the NSQIP, the American College of Surgeons NSQIP calculation. It's a surgical calculator, very well known. And if we really fill all the different age and so on, we come up with some sort of serious complication along the patient is in the hospital, readmission, and so on. And this is based on millions and millions and millions of surgery in the States. Okay, but I'm just going to the next one and thinking about for a moment in terms of risk stratification. And I would like to divide in two areas. One is non-modifiable risk factors. So type of surgery, obviously, the surgical setting, right? The age of the patient, and some of the comorbidity we cannot change, obviously. We can maybe modify, but very little. But then we have a modifiable risk, which is basically sarcopenia, loss of muscle mass, the frailty, physical activity, cardiorespiratory reserve, of course, alcohol, nutritional status, emotional status. So all these constellation of events produce what we call functional capacity, the capacity to live, to exist, and to move around, and therefore participate to be a member of this society. So we call it population health. So why is important the functional capacity? Because low functional capacity, as we saw from the constellation, is increasing morbidity, length of stay, low quality of life, increasing mortality. So functional capacity is important. The patients are able to move around, to walk, to feel strong, and go to the bank, and go and see a friend because of functional capacity. The moment they don't have that, basically, they feel impaired. So let's pay attention to that. And there are different ways how we can measure. I like very much this cartoon. This was a paper came out from the Michigan, where they look at patients, surgeons, or hospital. So on the left, you have the proportion of variance of complication. So the patient contributes 35%, the surgeon 2.4%, hospital 1.8%. So they look at over 15,000 colectomies, and the complication rate was 15.8%, which is pretty good, I think. Okay, but let's look at from this the second vignette. So you have, if the least comorbid patient, that means patient is reasonably fit, where the surgeon performance high or low, and hospital performance light or low, really the risk complication is very low, 1.5, 6.3%, very low. Okay. The moment we put a comorbid patient who is not really functioning properly, look, the surgeon, even the surgeon performance with a high performance, very good performance, and very good hospital, you have a 66%. And then if you really have low performance, you even 89%. So what shows this to me very much, and I think it's great, is that really we're dealing with patients who are comorbid, they're very poor functional. And this is where the problem is. So we have a fantastic surgeon, we have a great anesthesiologist, good hospital, but definitely, you know, we have patients in front of us more and more. And this was in October, I think February, I don't remember exactly, in The Economist. And it actually shows that it was quite a good article, where 80% of the burden of disease in the Western countries is caused by lifestyle factors. Smoking, drinking, sedentary, obesity, and we know all about it. That's what the patient we see today. That 40, 50 years ago, when I started anesthesia, basically it was much easier. We had the AS1 and 2. The big case, we didn't operate, we canceled. Now, nutrition is very important. You can see malnutrition is a problem too, and we see more and more. We don't think of malnutrition because the patient is cachectic, is malnutrition. No, it's obesity is malnutrition. And you can see that malnutrition has an impact. So as a surgeon, really we should be aware. As a physician, we should be aware malnutrition is a problem. This came out in the Lancet very recently. Actually show large number of patients in 75 countries, malnutrition, severe malnutrition, while the GLIM diagnosis was 33%. We're talking about one in 3 people, or 10%, 30% are increasing mortality, risk of site infection, and of course, this is independent of the income. So the functional capacity and nutrition are big problem. So what do we actually do today? We have a pre-existing medical condition. We are very good. We don't cancel anymore. We know exactly what to do. We have pharmacological, procedural. We got our internists, our geriatrician. They are great. What do we do about nutrition? What about physical and mental? I'm not sure we do very much in the preoperative period. So in the preoperative period is this the reference. So we've been thinking about to actually identify some elements, some patients we can actually stratify and think about where really we need to put our money, I would say our resources. So the frail, the condition, the patient is exhausted, and you see very much coming to your surgery. The DASI index, that is very easy to calculate, less than 34, then you have a problem at risk. The 6-minute walking less than 400 basically is impaired even to walk the street, the line street. Patient who has lost weight, a BMI over 40 necessarily can be sarcopenic or less than 18. Depression is a big problem. Cancer, think about our anxiety, depression. Patients don't move, don't walk. They're really depressed, so they don't really. And then all the list of medical evaluation, anemia, and so on, comorbidity, delirium, and major surgery. So what we develop at the clinical prehabilitation, we develop a consultation. So the surgeons send us, only by the surgeon, sometimes of course the nursing or physiotherapists and so on, that we have elaborated this in French and English because Montreal is bilingual. So we have a patient who is frail, as you can see here, could be old, could be anemic, low albumin, low hemoglobin A1C, hemoglobin, high risk, adjuvant therapy, of course, smoker, heavy smoker, major surgery, obviously, and weight loss. So basically, this helps us, helps the surgeon to identify who are the patient really need to be taken care of. And then we do the screen. This is the screen, as you can see on your left. Nutritional, emotional. And if we find that these patients are less than 30% over loss, then really we call the dietitian, we call the physiotherapist or kinesiologist and say, hey, do a proper assessment. Let's do the risk assessment, dietitian, and then intervene. So, and then what's happened, all the time we assess, we monitor, and after the intervention, we really go back and see is there any improvement, any increase. So this is where I think is important. The screening is very important, And that's where we should put the money in, because we know that the point, if the patient is not really functional, we need to actually improve. So this is the model we developed. And why is that? Why I put the center of the functional reserve? Because that's where we said, if you have a reserve sufficient, you can function in life. But of course, we have medical optimization. I don't deny that, alcohol reduction, smoking, and then anemia. I think this is clear that you must do that with the help of the internist, geriatrician, but we have to consider the other things because they're part of the functional capacity we talk about. So aerobic exercise, strength, flexibility, and balance in elderly patients. The falls, it tells us very much, and also the nutritional aspect we mentioned, and the psychological intervention. So really you need really this, again, all this work together to improve, increase, maintain such reduction. Food is a medicine, and exercise has to be prescribed. It's not just prescribing just like that exercise, must be structural and personalized. Food the same must be thought about according to what the patient is needing. Since we don't have time, I just go back very quickly to actually show that these are the 4 major studies, randomized controlled trial. We started in 2010. And then we're here in colon surgery, in esophageal one, in lung, and in bladder surgery. And that's we show very much, as you can see, that the top blue or the yellow show that the patients are in rehabilitation. They improve during the rehabilitation period before surgery. Then, of course, the stress response comes in. Patients, of course, are affected, but they come up and they're always above the line. 80% of patients go back to normal, to preoperative baseline. And that's what we want. We want to make sure that as 8 weeks, 9 weeks, these patients are really running. They go around, they walk, they go back to their own activities. So just briefly, this is a study. What about outcome, clinical outcome? Surgeons always ask, yeah, but what about the reduction in ICU, reduction complication? Well, there are 3 studies. First is the neurosurgery comes from Barcelona clinic in 2018, high-risk patient, dramatic increase in postoperative complication. Great work published in Neurosurgery. And this is the cost as well, showing the really reduction cost. This is a study from the Netherlands in neurosurgery again. You can see a dramatic decrease in postoperative complication again here. And the last one is the very recent, the largest randomized control trial in colon again, 250. And we participate with also the Ferrara, and we're seven centers. And actually, there was 4 weeks multimodal rehabilitation program, high intensity exercise, 3 times a week supervised nutritional intervention. I think what I want to show here is the complication. And what is interesting, you can look here, is the medical complication is the one or significantly less. Now, does it make sense? Of course, does it make sense? Because definitely we gear to manipulate very much the physical functional aspect. Simple complication, not very much. It was still different, but the severe complication is that, and also length in ICU, the duration in ICU was less. So what we have done now, we developed this integration within the preoperative clinic. So we work on the same, we are on the same level in the preoperative clinic. So the patient comes either, as you can see on the left, the patient comes from the surgical clinic, comes to us, we do the screening, and then if necessary, we just go intervening and rehabilitation. But at the same time, we communicate with the pre-op clinic. So the pre-op clinic can send the patient to us if there's not been sent. And then what we're going to do, we decide optimizing. And we talk to the surgeons as well and say, hey, the patient is not ready for surgery, go back, delay, or allow us to cancel the patient if necessary, or or proceed. And here we are. So in a way, the trajectory therefore is very much to improve the question. If you do a traditional in brown, you can see the patient stays there functionally, goes down, we see, and then takes time. That's tradition. If you have ERAS intervene, as you see, the blue line intervene operatively and accelerate the recovery. If you put Prehab plus ERAS, here we are. You have not only before, but they maintain. So what is the message? Don't forget that nutritional, mental, and physical are so important for the patients. If they are reduced capacity and they malnourished, are high risk of their recovery, despite their own, you optimize your blood pressure, you optimize the diabetes, still you have a problem with that. And the question of when they are risk, they have to be assessed, hospitalized, and that's where integration with them is very important, because it's a multidisciplinary approach for the rest of the patients. And with that, I conclude. If you're interested, we run a workshop all the time, every year in December, 2 days, virtual, and on a workshop on how to set up a surgical prehabilitation. Thank you very much for your attention.
Okay, Professor Carli, fantastic conference. Thank you very much. The next one, Professor Carlos Feo, he's going to speak about EUPNM project. And when you want.
Okay. Thank you. Unfortunately, I'm not able to project the slides myself, and kindly Professor Ramírez will do it for me. Thank you very much.
Okay.
Thank you. And first of all, I want to thank you very much for this very kind invitation. It is for me a great pleasure and honor to be here to talk to you about the implementation of enhanced recovery program across Europe through the EUPNM project. And also to have the chance to see again very nice friends. Next one, please. And thank you. And in the next few minutes, I will try to explain what is all about the EUPNM project, the aims and objectives of such a project, and the results achieved and impact, and also the future perspectives. Next one, please. EUPNM stands for European Perioperative Medical Networking, and it's an Erasmus Plus program project. So it is funded by the European Union through the Erasmus Plus program, a European program for education, training, youth, and sport. It is a 2-year project which has been developed in 2021 and 2022. And the goal of the project was to bring together the expertise and experience of national clinical champions who had previously helped to deliver major change programs in their countries, and to use them to help spreading the ERAS protocols in Europe. Next, please. And specifically, the objectives were to prepare an educational project and to implement in a number of European hospitals the evidence-based ERAS protocols in a homogeneous and standardized way, and also to collect data about the hospital stay, morbidity, and mortality of European surgical patients to improve the appraisal of the surgical risk of an individual patient, therefore to prevent perioperative complications. Next one, please. So 5 partners from university hospital in 4 different countries participated in the EUPNM project. 2 centers were in Spain, 1 in northern East Italy, 1 in Prague, Czech Republic, and finally 1 in Thessaloniki in Greece. Next one, please. And the coordinator center was the IIS in Aragon. Then we had in the northeastern Italy, University Hospital in Ferrara, CUNY, University of Karlova in Prague, Czech Republic, UMH, the Universidad Miguel Hernández de Elche in Spain, and finally the General Hospital Papa Nikolaou in Thessaloniki in Greece. Those are the 5 partners. And next one, please. We had in Aragon, José Manuel Ramírez, Sergio Benedì, Marta Teresa Fernandez. In Italy, we had Carlo Feo with Antonio Pesce and Nicolo Fabbri, Petr Koshan and Adram Whiteley in Prague, Luis Sanchez and Antonio Arroyo from Elche in Spain, and finally Orestes Ioannidis in Thessaloniki, Greece. Those were the one mostly involved in the development of the project. Next. In the UPNM projects were involved target groups, and specifically direct target groups involving health professionals in charge of surgical patients' care, such as surgeons, anesthetists, and nurses, but also professionals who are related to the interdisciplinary treatment of these patients, such as dietitians, somotherapists, physiotherapists, rehabilitators, geriatricians, and then health center administrators, clinical managers, quality coordinators, because effectiveness in terms of hospital stay reduction and optimization of the use of other resources is one of the advantages of these programs, and therefore also those people were involved. Indirect target groups constituted by primary care physicians and patients also play an active role, and finally stakeholders such as local, regional, national authorities and disease associations. Next one, please. So the specific activities were, first of all, the preparation of an enhanced recovery manual and 7 protocols in different areas, such as bariatric surgery, esophageal surgery, gastric surgery, colon surgery, intestinal obstruction treatment, appendectomy, and hepatobiliary surgery. And those were followed by the target groups. Next. Another important activity was the learning, teaching, training, thus to teach the future teachers the different protocols in order to be able to teach them in different hospitals. And this activity was done during transnational meetings. Then we developed a UPNM online platform to host the protocols, the e-learning training course, and to represent a collaborative area to improve and participate in the ERAS protocols. Next. Disseminated the activity of the project in multiplier events held in the different countries. And finally, we held some transnational meetings in order to plan the activities of the project, follow up their development. And next. Next one, please. Thank you. We had some virtual meetings also because we had, unfortunately, the COVID restriction at the beginning of the meeting, but also meeting in Ferrara in September 2021. Next. And in May 2022 in Greece, where we had very hard work, but also some nice moment to meet and gather with the other participants in the project. And then finally, we met in Prague in October 2022. Next. The ERAS manual was mostly based on the clinical pathway Via RIca. The RIca pathway, the English version had just been delivered, so we had some English polishing of the text by a mother tongue, and we decided to offer the manual only in the English version, so not to translate the manual in the different languages. Next. Then we developed the 7 protocols for bariatric surgery, esophageal, gastric, colon surgery, in the treatment of intestinal obstruction, appendectomy, and hepatobiliary surgery. The protocols were based on the protocols delivered by Herm. They were revised by groups and by reviewing all the available protocols for enhanced recovery in national and internationally, and then they were discussed during the transnational meetings, and the final version was available in English and then translated in Spanish, Italian, Czech, and Greek. Next. Thank you. The protocols covered all the different items to be implemented in the program before the admissions and the health professionals involved, and in the perioperative and immediate preoperative period, intraoperatively. Next, please. In the immediate postoperative period, and then specifically in postoperative day 1 in the ward. Next, please. In the following days up to discharge. Next, please. Then we prepared some online learning activity. José Ramírez addressed the RIca pathway, Petra Koshan from Prague, the preoperative preparations, José Luis Sánchez from Elche, the use of drains and nasogastric tubes, Anna Pascual from Zaragoza, both the anesthesia and the nursery, and Orestes Ioannidis, the nutrition aspects. And I personally addressed the problems with the implementation of scientific evidence and recommendations and guidelines regarding difficulty of adherence and sustainability. All the video lectures were in English, but the slides were also available on the platform in Spanish, Italian, Greek, and Czech. Next, please. And this is how the platform, the website UPNM looks like. We have the manuals available, the 7 protocols, the e-learning activity, the events we held in the different countries, and then the contacts. Next, please. This is an example of the protocols that are available in different languages, in English, in Spanish, in Italian, in Greek, and in Czech. Next, please. And these are the multiplier events that were held in Italy, in Greece, next, in Czech Republic, and in Spain. They were all held in October 2002, and over 200 people participated to these events, during which basically the informations regarding the UPNM project were spread. Next, please. So, through the UPNM projects, we achieved the development of enhanced recovery program protocols, training program for health professionals. We train multidisciplinary professionals, all direct target groups involved in perioperative procedure. We were able to implement enhanced recovery programs in at least 5 hospitals across Spain, Italy, Czech Republic, and Greece. Finally, we created a professional network with the capacity to train stakeholders in hospitals and to audit the trainers to guarantee the correct implementation of the program. Next, please. The long-term effect were to decrease the secondary effects after surgery for patients, consequently with a faster recovery, reduce morbidity and mortality after surgery by the implementations of the program, and to reduce the length of stay in the hospital and consequently save money for the public health system, and to have more free beds for other new requested patients, and so to optimize resources. Next, please. Then the partners constituted a research group, and we published in the Journal of Clinical Medicine the UPNM protocol for bowel obstruction. Next, please. And now we are working on a multi-center international study on the incidence and risk factors for prolonged postoperative ileus in elective colorectal surgery. We constituted and shared a database. The protocol was approved by the Ethics Committee in Czech Republic and now has been submitted. Is under revision in the other centers. Next, please. So in summary, the UPNM is a multi-center international European project funded by the European Union through the Erasmus Plus program. Is an educational project to favor the implementation of enhanced recovery protocols in Europe and to collect data on hospital stay and perioperative surgical care across Europe. And this was mainly achieved through an online platform free of charge, offered free of charge, to offer evidence-based standardized perioperative care protocols and learning activities, assistance to health professionals interested to enhance recovery of their surgical patients. And finally, we established an international collaborative research group to increase the power of the studies on perioperative care for the surgical patient. Next, please. And I thank you very much for your attention.
Okay, Carlo, thank you very much for your conference. Vamos a pasar a la última presentación, que es la que comentaba que está grabada por la doctora Ocon. Cuando podáis la podéis insertar, por favor.
Buenas tardes. En primer lugar, pediros disculpas por no poder estar hoy en directo con vosotros y también pues me da mucha rabia no poder compartir esta mesa redonda con estos ponentes y moderadores de prestigio nacional. También dar las gracias a Fresenius Kabi por haberme invitado a esta webinar. Y bueno, pues mi tema es la nutrición y siempre me gusta empezar con esta diapositiva que refleja muy bien el problema de la desnutrición en el paciente quirúrgico y así, pues bueno, 2 de cada 3 pacientes que están desnutridos o en riesgo de desnutrición se van a someter a una cirugía, que la desnutrición aumenta el riesgo de complicaciones posoperatorias hasta 3 veces más y de mortalidad hasta 5 veces más y que a pesar de ello solo 1 de cada 5 hospitales en Estados Unidos pues tienen un protocolo de cribado nutricional y también que solo 1 de cada 5 pacientes desnutridos reciben un tratamiento nutricional antes de la cirugía. Bueno, todos sabemos, ¿no?, que la desnutrición preoperatoria se asocia con un aumento del riesgo de complicaciones posoperatorias, sobre todo la infección del sitio quirúrgico, el retraso de la cicatrización de heridas, el aumento del riesgo de discencia de anastomosis. También se prolonga el tiempo de recuperación del tránsito intestinal y todo ello prolonga la estancia hospitalaria y hace que la capacidad funcional del enfermo pues empeore. Este es un trabajo que me parece muy importante del Servicio Nacional de Salud de Gran Bretaña, donde se ha analizado a 7.500 pacientes de 75 pacientes y donde se demuestra que la desnutrición severa aumenta el riesgo de mortalidad en todos los países del mundo, independientemente de sus ingresos económicos, pero sobre todo los pacientes con ingresos bajos pues tienen un riesgo de mortalidad 11 veces superior. Bueno, yo creo que todos sabemos, ¿no?, que la desnutrición y la pérdida de masa muscular en el paciente quirúrgico tiene una etiología multifactorial. Por un lado está la patología por la que se va a operar al enfermo, normalmente suele ser un cáncer. El cáncer libera citoquinas proinflamatorias que son las responsables de la anorexia y del catabolismo proteico. Además, a esto hay que añadirle que muchos de nuestros enfermos reciben quimioterapia o radioterapia y que como efectos secundarios suelen ser digestivos, van a reducir la ingesta nutricional. Además, cada día se opera a enfermos de más edad, con más comorbilidades. Son enfermos que van a tener un riesgo nutricional alto per se. Y también tenemos que tener en cuenta el abuso innecesario del ayuno, que también genera catabolismo proteico, y del encamamiento al que se someten a nuestros enfermos, que hacen que haya una pérdida importante de masa muscular esquelética, sobre todo en extremidades inferiores. Todos estos datos que os he comentado, pues nosotros tenemos resultados en España. Este es el recién publicado estudio PREMAS, es un estudio multicéntrico donde se analizó a casi 500 pacientes que iban a ser sometidos a cirugía mayor en España, y como podéis ver, pues la edad de los enfermos casi era de 70 años, la edad media. Ya veis también que la mayoría de los enfermos tenían una o varias comorbilidades, y también los enfermos recibían quimio y radio preoperatoria. La cosa buena es que pues casi la mitad de los enfermos estaban incluidos en programa RIca, y aunque aquí no lo veáis, pero un tercio de los enfermos recibían tratamiento nutricional preoperatorio. Bueno, pues la prevalencia de desnutrición en nuestro país, de desnutrición preoperatoria, es del 39%. También vimos cómo los predictores de desnutrición fundamentalmente es la localización del tumor, es decir, los tumores de esófago y estómago son los que más riesgo de desnutrición tienen, y también una comorbilidad importante como es la diabetes. Y también pues demostramos que en los pacientes desnutridos la tasa de complicaciones era significativamente más alta. Y con todo ello, pues en la Via RIca, en la que tuve la suerte de participar con todos los ítems relacionados con la nutrición, pues lo que recomendamos es realizar un cribado nutricional a todos los pacientes que van a ser sometidos a cirugía mayor abdominal, sobre todo por cáncer. Y cuando el cribado es positivo, tenemos que realizar una valoración nutricional e iniciar un tratamiento nutricional. ¿Y qué cribado nutricional? Pues el que más os guste, pero tiene que ser un cribado que esté validado y que incluya el índice de masa corporal, la reducción de la ingesta nutricional y la pérdida de peso. Y aquí, bueno, pues tenéis los más recomendados, pero yo personalmente me gusta mucho el MAS, porque está validado para población hospitalizada, ambulatoria, ancianos y no ancianos. Y bueno, aquí os presento como novedad el PONS, que es un cribado específico para el paciente quirúrgico, que lo desarrolló la Sociedad Americana de Recuperación Intensificada, que está validado y que, como veis, es el más modificado, en el que se incluye la albúmina como marcador pronóstico. Cuando el enfermo tiene un cribado positivo, debemos realizar una valoración nutricional, y hay consenso internacional en el que la forma de valorar a nuestros enfermos es usando los criterios Olin. Los criterios Olin ya los conocéis. Hay unos criterios fenotípicos que son la pérdida de peso, la reducción de la ingesta, la reducción del IMC y la reducción de la masa muscular. Y también hay unos criterios etiológicos, que son la baja ingesta nutricional o absorción y la presencia de inflamación. Entonces, cuando cumplimos un criterio fenotípico y otro etiológico, ya podemos hacer un diagnóstico de desnutrición. Como veis, aquí la palabra albúmina no aparece. Y esto es así porque la albúmina, como marcador nutricional, tiene muy baja especificidad y sensibilidad. Y hace un tiempo que ya la consideramos como un reactante de fase aguda, igual que la PCR, pero al contrario. Es decir, que cuando nosotros tengamos un enfermo con una PCR alta, pues con toda probabilidad tendremos a un enfermo con albúmina baja. Y eso no quiere decir que el enfermo esté desnutrido, sino que existe un proceso inflamatorio agudo como es la cirugía o una complicación. La albúmina sí que es un buen marcador de pronóstico y de severidad. Y bueno, este es un estudio con 2.500 pacientes donde se ve claramente esa correlación negativa significativa que existe entre la albúmina y la PCR. Y también como tanto la albúmina como la PCR son dos marcadores o predictores independientes de mortalidad con muy buenas áreas bajo la curva. Y bueno, pues a pesar de que tenemos claro que la albúmina es un marcador inflamatorio, pues todavía necesitamos seguir formando e informando, porque este es un estudio que publicamos el año pasado. Hicimos una encuesta sobre formación en nutrición a 150 cirujanos españoles y, como veis, pues el 75% consideraron que para hacer el diagnóstico de la desnutrición o la forma de diagnosticar la desnutrición era teniendo la albúmina baja. Y también había un 25% que todavía pues no tenían conocimientos, ¿no? o no conocían lo que era un cribado nutricional. La sarcopenia es una entidad clínica muy emergente en el paciente quirúrgico. Ya sabéis que se considera sarcopenia cuando el enfermo tiene una baja fuerza y masa muscular, y cuando nosotros perdemos un 10% de músculo esquelético, ya el sistema inmune se resiente y ya aumenta el riesgo de infección. Con un 20% pues ya hay un retraso de la cicatrización de heridas, y con un 45% puede haber un aumento de la mortalidad. La sarcopenia en el paciente quirúrgico se ha demostrado que aumenta el riesgo de complicaciones posoperatorias, que es un predictor independiente de peor supervivencia, que prolonga la estancia hospitalaria, la tasa de reingresos, empeora la calidad de vida porque van a tener peor capacidad funcional, y también una cosa muy importante es que van a responder peor al tratamiento antineoplásico, porque muchas veces va a haber que suspender el tratamiento sin completar la dosis o reducir la dosis o empezar más tarde. Y bueno, también conocéis la valoración morfofuncional, que lo que a veces hoy en día nosotros, además de hacer una valoración nutricional clásica, pues también valoramos la composición corporal de nuestros enfermos, sobre todo saber qué cantidad de masa muscular o de grasa o de agua. Tenemos diferentes técnicas, todas van a tener sus pros y sus contras, y os invito al taller que va a haber en el Congreso de la AEC el día 25 de octubre, donde se va a hablar de valoración morfofuncional. Y hoy yo no os puedo hablar. Y también tenemos que valorar la funcionalidad de nuestros enfermos, y la forma más adecuada es valorando la masa muscular de la mano con la dinamometría. En cuanto a la intervención nutricional preoperatoria, yo creo que el punto clave es el aporte proteico. Eso es lo más importante, y hoy en día el tratamiento nutricional tiene que ser sí o sí hiperproteico. Al menos hay que aportar 1,2 gramos de proteínas kilo de peso y día. Tienen que ser proteínas de alto valor biológico y, bueno, pues enriquecida en algunos aminoácidos esenciales, como puede ser la leucina. También tenemos que cubrir nuestros requerimientos calóricos, es decir, entre 20 y 30 kilocalorías al día. Tenemos que tratar todos los déficits de vitaminas y oligoelementos, pensar siempre en el hierro, en la vitamina D y la vitamina B12, que están bajas en estos enfermos. Y también podemos usar algunos inmunonutrientes, como puede ser los ácidos grasos omega 3, aislados o en combinación con otros nutrientes, como puede ser la arginina. Y nunca olvidarnos del ejercicio físico, tanto de aeróbico como de fuerza. En cuanto a la vía de acceso de elección, en el paciente prequirúrgico, la mayoría va a ser la vía oral, el empleo de la dieta oral junto con suplementos nutricionales. Cuando no se cubra el 75% de los requerimientos nutricionales en 5 días seguidos, entonces ya usaremos la nutrición enteral a través de una sonda nasogástrica y sobre todo la nutrición parenteral, dejarla para los enfermos con desnutrición crónica y que el tracto digestivo no sea funcionante o bueno, cuando no se terminen de cubrir los requerimientos nutricionales con la nutrición enteral y la vía oral. ¿Cuándo empleamos los suplementos nutricionales? Pues según las guías ESPEN, los suplementos nutricionales los emplearemos en todos los pacientes desnutridos con cáncer, es decir, el gran porcentaje de los enfermos, y también en los ancianos con sarcopenia. También lo usaremos cuando, aunque el enfermo esté bien nutrido, pero pues no cubra el 75% de los requerimientos nutricionales. ¿Y qué suplementos nutricionales? Siempre hiperproteicos. Un suplemento que al menos tenga 18 gramos de proteínas por envase, por brick, porque necesitamos aportar entre 25 y 35 gramos de proteínas en cada comida junto con la dieta para tener ese efecto anabólico y de síntesis proteica. ¿Y durante cuánto tiempo? Pues este es un trabajo muy interesante en 1000 pacientes donde se demostró que aquellos enfermos, casi la mitad de los enfermos, que estaban desnutridos y se inició una nutrición enteral o parenteral, durante, esto es lo importante, al menos una semana, pues se demostró que en aquellos que tenían un riesgo nutricional severo y que estaban una semana con nutrición enteral o parenteral, eran los que se iban a beneficiar en términos de reducir las complicaciones posoperatorias, infecciosas y la estancia hospitalaria. Mientras los que tienen un riesgo nutricional leve, el tratamiento nutricional, entendido como enteral o parenteral, no demostró grandes beneficios. Y este también es otro trabajo con 800 pacientes, este caso es cáncer gástrico, pero viene a demostrar lo mismo que aquellos enfermos que estaban desnutridos y que recibieron al menos 10 días tratamiento nutricional, enteral, parenteral, oral, eran los que iban a tener una menor incidencia significativa de complicaciones infecciosas comparados con los que no recibían tratamiento nutricional o con los que recibían menos de 10 días. Así que nuestra Via RIca lo que recomienda es que a todos los pacientes desnutridos o en riesgo nutricional severo deben recibir tratamiento nutricional al menos 7 o 10 días antes de la cirugía. Y bueno, pues yo con esto ya he terminado. Si tenéis alguna duda, alguna pregunta que hacerme, las podéis trasladar a Fresenius Cavi, que ellos me las trasladarán a mí, y si no, yo el día 25 de octubre estaré en vuestro congreso. Muchas gracias.
Muy bien, pues nada, también fantástica charla y conferencia de Julia. Ya le daremos las gracias personalmente en Alicante. Vamos a empezar la ronda de un poquito de preguntar a los ponentes. Empezaremos con el profesor Carli porque nos pidió en su momento que a las 8, cambio horario y agenda que tenía allí en su país, nos tendría que dejar. Vamos a hacer alguna preguntita y luego ya nos quedaremos un ratito con Carlos, sin estirarlo tampoco demasiado. Pues nada, José Manuel, hay muchas preguntas en el tema. Pues adelante.
Franco, can you listen to me? Okay, there's a question in the chat. How much time does the McGill screen take per patient?
Yeah. Okay. So once we receive the referral from the surgeon, generally within the next 5-6 days, we get the patient to come, and we explain everything, obviously, to the patient. But we tell them when they come, they have to spend at least 2 to 3 hours with us. So they know exactly, they have to bring some comfortable shoes, they have to bring something to eat if they want to, but that's because it's one shot, one time they come and get everything done. So they get bloods done. If there is an echo, we do an echo if it's necessary. We have internal medicine, we can actually do internal medicine another time, but we have a functional assessment. Then we have with a physiotherapist or kinesiologist. So grip strength, time up and go, 6-minute walking test, sit to stand. All these are easy to do it. And then we have the dietitian. If we identify that the patient is malnourished, obviously, and so on, then we know with the dietitian. Otherwise, if they are not malnourished, because we have a questionnaire, we give a questionnaire by email, so we know exactly whether they're malnourished or not. If they're malnourished, then we see. If they're not, then generally they get a class, a nutrition class, which generally is about improving care and so on. So within the time, maximum 3 hours, maximum, I would say 3 hours, they get also an intervention. Okay, we describe that patient has got many falls, or the patient cannot come to the hospital. The patient can come to the hospital. If they come to the hospital, or they are doing chemotherapy, we want them to come to the hospital and supervise exercise. So there is a supervised exercise, aerobic and resistance, flexibility, obviously, with the supervised once a week, twice a week, depends. It's very much to individual level. The patient who cannot come, then we have a system at home. Now we're developing more and more a sort of Zoom type, and we know exactly what they do at home, but they have to be, we think they are supervised, they have to be supervised. We classified based on that, we classify whether they can come at 4 weeks, 6 weeks, depends. If the patient is a cancer, generally within 4 to 6 weeks. If the patient is not cancer, like vascular, for instance, then we can go for 6 to 8 weeks, depends. And a patient with large ventral hernia, we have a large ventral hernia, which are complex cases, obviously. And so it really is very much, the screening is crucial. And then we follow them. They come back before surgery to check how we're doing. And then we follow them up to 8 weeks post-op. So they come again after 8 weeks. So the screening is the crucial things that you probably have to spend a little bit of time. But the surgeons know exactly, because we're giving a limited number, you see, of cases to come.
So in this context, we have a question from Carlo Brugiotti. You're telling us that you select the patient going to prehabilitation. Not all patients are going to prehabilitation, but
no. That's why the list that the surgeon give us. Okay, we send to the surgeon. This is a referral list. So we already identified that these are the patients we can actually modify some of the factors: smoking, heavy smoker, sedentary, obesity to some extent. So it's very specific. So if they come, we know that is the screening. The screening, we know the level that we need to intervene. But otherwise, they know very well. The surgeons know very well. They cannot send okay, go to prehab. No. They have to specify why they're bringing it to us, send it to us.
So, Carlo, do you have any data about obesity? The obese patients, are they, because you have a question about this, the obesity patients are going much better than others. What do you think about this?
Yeah, much better. I don't know about that. But anyway, definitely, I mean, we don't do bariatrics, just there's a different bariatric. But we have obese with an average of 38, 40, let's say, BMI, okay, come with large hernia. Okay, there are a few surgeons can do that. So they're complex case because it's behavioral, obviously, and so on. So we established some criteria. Okay, we go up to 3 to 6 months. We allow them to come with us, and we're expecting that definitely they lose at least 7% of the body weight or BMI, right? Then they have a diabetes well controlled. And then they stop smoking. These are 3 criteria that we see absolutely essential. And then if they don't reach that criteria, we tell the surgeons and say, look, don't put on the list. If you want to put on the list, then we can take care. We can take care, but on one condition, that the patient has to follow this criteria. Otherwise, we say no. Patient has not reached the criteria. We cannot do anything about it. So they have to have another system. Also because otherwise they take a place for somebody else. So we don't have many resources to do it. We run daily from 8 o'clock to 4 o'clock, and we have our personnel is one who is the administrative assistant, call the patient, organizing all this stuff. Then we have a nurse, we have a dietitian, the nurse full-time, dietitian, which is part-time, off-time, and then we have a kinesiology physiotherapist who is full-time. Plus we have two nurses, retired nurse, who actually have done a lot of oncology, and they do the psychosocial aspect and so on. So, you know, so it's really, to some extent, rather intensive, obviously, but the personnel and the clientele had to be very focused. We cannot spend resources on everyone, absolutely.
Okay. Last question, José Manuel. Last question to Franco. A fast question. Professor García Erce is a specialist of anemia in Spain. Asked that you have put in one slide that the pre-test nutritional evaluation anemia with less than 10, the value of 10. For you is not is important or is not important the value of anemia?
Absolutely. Yeah. Well, actually, to be honest, you know, the WHO guidelines say really at the moment you are less than 130, you're anemic. But of course, we don't mind to go down. All depends very much what is the reason. If it's colon, we know is iron. Otherwise, we just do a screening. But basically, we tell the surgeon, the gastroenterologist, don't send to us, or the lung surgeon, don't send to us if you haven't done even the hemoglobin, you know, value. So then if we know that, we have an internal medicine working with us. We do a screening of ferritin, iron saturation. That gives an idea. CRP. We do CRP on everyone. And we do hemoglobin A1C in everyone. CRP telling us there is definitely an issue. I don't believe in albumin, to be honest, as a nutrition, but it's an inflammatory marker as well, you know. Okay, so once we know the anemia, we start straight away in iron infusion. We go monoferric iron infusion. We believe that you have to have 4 weeks, 3 weeks. So this patient otherwise arrive there and they are not ready. The large studies was, you know, I didn't like very much the result, but because they gave it 2 weeks before. 2 weeks before, you cannot really correct anemia. But if it is anemia, which actually comes after of inflammatory, like patients who have, for instance, cancer and so on, or chemotherapy, then I think that's where we need a little bit of help from our, I don't think we need a hematologist. I think we need an internal medicine who guide us whether it can give IPO or you can give us something else and so on. But definitely you have to correct anemia. So we are strong believer that anemia has to, at least 30–40% of our patients are anemic.
Okay, perfect. José Manuel, if you think we can finish with Professor Carli, because we have compromised with him to finish at 8 o'clock, he can go to another.
Franco, thank you very much.
Thank you very much.
It's a pleasure as always.
Yeah.
Thank you very much.
Thank
Franco.
you. Thank you all of you. Bye-bye.
Bye. Carlos, I have a question because the UPMN project.
Yes.
Could you tell us, is the problem we have in Spain are the similar problem you have in Italy? And in Italy, the same problem as in Greece? I mean, this is a problem in all Europe.
Yes.
I mean, implementation of the program.
Yes, of course. And the idea of the project was, first of all, to offer a tool which was free of charge. And so there was no barrier as far as money was concerned for the hospital. And then also to offer some material in different languages, not only in English, no? And so to overcome a language barrier in which in some rural area could also be a problem. So in this way, we gave material, we gave support and training to help spreading the methodology of enhanced recovery. And we felt that in Italy, as well as in Greece in the Czech Republic, this was really needed. I know that in Spain, an excellent work has been done by the Grupo Español de Rehabilitación Multimodal, which is a very, very good, important association that offers a lot of support for enhancing recovery of the surgical patient. But we felt that it was important to have also the protocols and the support available in different languages and not only in English.
One of the main problems we are having here is to pass the knowledge to surgeons that they are very much involved, or to nurses and so on. But what about our general managers? This is very difficult. What is your opinion about how to jump to the establishment, to the general managers and to the politicians?
Well, they have to see the opportunity to save money. They have to see the opportunity to save money by reducing complications and reducing the hospital stays. I think this is the most powerful argument for the hospital manager, honestly. We are more interested in the benefit for the patients in terms of less complications. I think that they are mostly interested in saving money to have more resources. And so they have to see that by these programs, we really have the opportunity to reduce the hospital stay and to reduce the complications of the patients. And they have to be involved from the beginning and in the process of implementation.
I believe there was not a good response from these general managers of the project. What is your opinion about this? It was difficult for us to contact
them. I noticed that recently there is more interest from the manager towards enhanced recovery programs as compared to the past. And I think that is because they are starting to be aware that there is the possibility to save money by implementing these programs. And this is what they're really interested at.
So just the last question from my side. How do you see this in Europe? I mean, for the future, are we doing some research? That's okay, but what do you believe? We have to go to France, Germany, North Europe countries. So what is your way to all these countries?
To implement in our countries the enhanced recovery programs, you mean? Yeah, I think that by going to Spain and also to Greece, I think that the problems are always the same. The barriers are always the same. The problems to implement such a programs, they are very much alike. Although the country may be different, it's very much the same. So I think it's very important to establish network and to share experiences, because the solutions that maybe in Spain or in France or in England has been found to problems of implementations may help a lot in Italy or Greece. So I think it's very important to establish network for enhanced recovery for this reason. And now we really need to analyze how to implement the programs rather than if they work or not. I mean, we have the data on that.
Yeah.
We really need to better the implementation.
So perhaps there is a problem of money, because what we want to implement to all countries are programs for free. That is, any surgeon in Europe use this kind of programs and the data system and so on for free. This is taking a big issue, right?
Yes, of course. And it's important to have, if possible, your own data in your hospital. Because, of course, when I've been able to show that in our hospital we have saved about 1,500 euros per patient with the program, that had more an impact on the administration rather than the literature. So if you really can collect some data from your area, this is very powerful. I think is very important.
Bueno, pues thank you very much for your time.
José Manuel, yo creo que hemos cumplido en horario, en intensidad, en conceptos. Antes de terminar, vamos a pasar una encuesta que os pedimos que rellenéis a los asistentes. Mientras vamos despidiendo aquí tienen la encuesta, el profesor Carlo, CEO. Muchas gracias por acudir a nuestra llamada, por compartir. Thank you very much.
Gracias a voi.
Por compartir la experiencia europea. We have to begin the new step or a new phase of evaluate the implementation in our group and to extend these guides and this group to another countries. That we have the obligation of do it. Okay, then thank you very much. Gracias a todos por estar hasta tan tarde. Esperemos que hayáis disfrutado, que os haya sumado en vuestro día a día. Contestar la encuesta y a continuación pondrán la próxima webinar, que será, si no me equivoco, el próximo jueves, día 19, a las 7 de la tarde. Inteligencia artificial, también muy interesante. Y nada, y nos vemos todos en Alicante semana que viene. Gracias, Carlos. Gracias, José.
Gracias, Antonio. Thank you very much, Carlos.
Gracias a vos.
Nice talk. Thank you very much.
Okay, thank you.
Gracias.
Bye.
Bye.